Welcome, and I hope you enjoy our presentation on the peaceful end-of-life theory. Peaceful end-of-life theory was developed by Cornelia Rulin and Shirley M. Moore. Rulin is the Director of Research at Pitlock University. Hope I said that right. At Oslo, Norway. She's also a faculty member at Columbia University. Ms. Moore is an Associate Dean at Case Western University and is a co-author of numerous papers on picking theory, especially middle range theories. They both got their PhD at Case Western University, is where they actually, Ms. Moore was a teacher of Rulin. The theory was developed as a need for direction for nurses who were taking care of critically ill patients. Rulin saw this need as she was doing a standards of care paper. It's actually 16 pages of developing the standards of care for taking care of terminally ill patients that she later developed in this middle range theory along with Moore's help. Said again, it's a middle range theory and it was linked with the standards of care as a steady progression as a middle range theory.
Okay, so real quickly I'm going to go over the practice experience. Dr. Shirley Moore mainly dealt with recovery of cardiac episodes, health behavioral alterations, exercise after cardiac episodes, obesity, and safety and quality. She was also a doctoral nursing instructor. Cornelia Rulin was a student at the time and had spent previous years with Norwegian nurses dealing with terminal cancer clients. She, along with the other nurses, developed a peaceful end-of-life clinical practice standard. And together, Moore and Rulin recognized a need for clinical counseling for nurturing for these clients and to give them excellent care. This developed into the theory for the peaceful end of life. The theoretical sources, the peaceful end of life theory was based on a couple of theories. The first one I'm going to discuss is Donabedian's model of quality care. It's derived from the general system theory. The model of quality care deals with intricacies of the healthcare system. The model covers three areas, which are structure, process, and outcome. Structure is the institution, which is like the hospitals. Process is the client's interaction with the institution. And the outcome, of course, is the effects of the health care. And then we're also going to look at Hakim's preference theory. And this was basically like a study that she did about women and their lifestyle choices as far as like staying home or working, all those different, aspects. But it basically is the same premise for, lifestyle choices, period. Also, on Michelle's reconceptualization of uncertainty in the illness theory, this was an idea to revise the illness theory because it mainly focused on acute illness and not so much chronic or continuous illness. Rulin and Moore also found some credible sources in Kalsaba's analysis of the concept of comfort, and this is just basically, as we all know, analyzing the concept of comfort and its different meanings, be it physical, emotional, all of the above. On the empirical evidence, what they used experienced nurses that dealt with cancer patients, and they had 5+ years experience. They also did a review of literature that was peer-reviewed and published. Next, we're going to review primary sources. And in the end-of-life, peaceful end-of-life theory, they used several articles. We're going to review 3. The first one is a 1996 article of Moore and Goods that focused on acute pain. And this is to recognize discomfort and the need to be pain-free. Another source that was used was Michelle's reconceptualization of the uncertainty in illness theory, which was published in the Journal of Nursing Scholarship in 1990. It explores the idea of revision to the illness theory as it only pertains to acute illness and not specifically to chronic or continuous illness that someone might have to face. Another one was Kolsaba's and Kolsaba's analysis of the concept of comfort. And this is just defining and exploring all the different ways that comfort can be explained, and the definition has different meanings in different situations. It could be physical, it can be emotional, etc.
Addressing the nursing meta-paradigm in the peaceful end theory. The peaceful end theory addresses the meta-paradigm on all 4 levels. The 4 levels being the client or person, the environment, health, and nursing. In the peaceful end theory, every client is said to have a unique experience, a different end-of-life experience. In other words, no 2 clients have the same end-of-life experience. The environment in the peaceful end theory needs to be a calm, peaceful environment, the type of environment where the needs, desires, preferences of the patient as well as the family or significant others are effectively addressed. In the peaceful end theory, health is a balance of maximizing care and avoiding over treatment, because the patient is at the point where we're doing palliative care or comfort care, so healing is not the goal. Nursing in the peaceful end theory, nursing is said to be essential to creating a peaceful end for the patient. There are certain functions that nursing can perform to help create this peaceful end for the patient. Major concepts and definitions in the peaceful end theory. Major concepts are not being in pain, experience of comfort, experience of dignity and respect, being at peace, and closeness to significant others. Not being in pain simply means the absence of suffering associated with actual or potential tissue impairment. Experience of comfort is a state of ease attributed to the absence of discomfort. Experience of dignity and respect. This concept encompasses the concept of autonomy. Patient and family or significant others' desires and preferences should be included in the course of care. Being at peace. This is where a balance between the physical, psychological, and spiritual dimensions of the patient exists. There's a balance between those 3 elements. Closeness to significant others. This simply means physical or emotional nearness to significant others or family members. Addressing the interrelation of the concepts on the schematic of the peaceful end theory. The peaceful end theory schematic does a very good job of depicting how the concepts all work together to collectively create a peaceful end for the patient. On the top level, you see what the patient will experience. The patient will have the experience of not being in pain, the experience of comfort, the experience of dignity and respect, the experience of being at peace, the experience of closeness to significant others. Directly up under those goals, you see the functions that nursing can perform to create a peaceful end for the patient. Nursing can help create not being in pain by monitoring pain and providing pain relief. Nursing can create the experience of comfort for the patient by facilitating rest and relaxation, preventing complications, and relieving discomfort. Nursing can create the experience of dignity and respect by allowing the patient's family, significant others to autonomously make decisions regarding the end of life process. Also, by approaching the dying process with empathy, the nursing can help create the experience of dignity and respect for that patient. The nursing can create the experience of being at peace by addressing anxiety and providing anti-anxiety medication, providing emotional support for the patient as well as the family, and also by providing physical assistance if needed. Nursing can create the experience of closeness to significant others by allowing significant others to participate in patient care by effectively addressing the grief of significant others or family members. There are four major assumptions in the peaceful end theory. The theory assumes that the end of life experience is unique for every patient. The theory also assumes that nursing is imperative to creating a peaceful end for a patient. The theory also assumes that family or significant others and their involvement is instrumental in creating a peaceful end for a patient. And the peaceful end theory also assumes that peaceful end is obtained by simultaneously maximizing treatment and avoiding overtreatment. The theoretical assumptions or the proposed assumptions of the peaceful end theory are facilitating pain relief, preventing pain, including patients and family members or significant others in decision making, giving emotional support, and allowing the family or significant others to participate in patient care all work collectively in facilitating the outcome of creating a peaceful end for a patient.
This part of the presentation has discussed the logical form that they used to develop the theory. They used inductive reasoning, coming from a broad to a smaller portion. The standards of care were used to focus the theory. Like I said at the beginning, 16 down to 5 outcomes. And it's used as a guide for nursing in multiple fields, not just as big as a grand theory, more as a logical form of a mid-range theory designed more practicing instead of just theoretical. The 5 simple statements were primary outcomes, as they discussed in the earlier in the presentation. The one flaw that I noted was the sample size they used for the nursing expertise was one hospital with nurses that had been working 5 years and had went to some conferences and developed themselves. But they didn't use other hospitals, or they did not use other countries to develop this theory. That was the only flaw that I saw in their logical progress. Theory in use can be, to me, described in 3 different ways. Used in practice, actual practice, taking care of terminally ill patients, or taking care of any patient that is approaching death. Used in research. The outcomes are easily measurable. We made sure, and also re-looked at their paper to see how they would measure their outcomes. And then the education of new nurses is essential, especially with the developing fields of hospice and palliative care.
What does this mean for advanced practicing nurses? In the healthcare setting, there will be an instant, or probably already has been an instance, where you've had to administer end-of-life care. It's critical to have the principal knowledge to react accordingly in this situation. End of life is a very sensitive matter, and it requires qualified professional caregiving. In our scenario, well, there it goes. I used a 75-year-old male status post liver transplant times 1 week in full transplant rejection that has signed a DNI because he's tired of messing with it. So we discussed with the family the end-of-life care plan and what to expect, both with the family and the client. And we explained that for pain, we can issue around-the-clock pain medication, anti-anxiety medication. We explained that the environment needs to be quiet and peaceful. We, of course, are going to provide the client with comfort physically and emotionally. We're going to provide a presence so the family and the client feels safe and reassured in their time of need, because this all can be scary, very scary. We're going to respect all wishes of the family and the client. We're going to converse with the client regardless of the client's neurological state. So we're gonna speak to the client like that they're wide awake and talking back to us. We're going to maintain privacy, and these are a few things. We went into a little more detail in our scenario, but these are a few things that are important when you're applying end-of-life care.
To summarize our presentation, we start with the end-of-life theory. The 2 theorists, Rulin and Moore. We discuss their 5 key concepts. Then we go from their logic theory, from standards of care to a mid-range theory. And then finally we ended discussing the ways it can be applied or used in research, education, and practice. Thank you for our presentation. Thank you for listening.